Hi, my name is Dr. Heather Gornik. I'm a vascular medicine specialist at University Hospitals Harrington Heart and Vascular Institute in Cleveland, Ohio, USA. I'm also a faculty member at Case Western Reserve University School of Medicine, and I am the chair of the 2024 Multisocietal Peripheral Artery Disease Guideline. Well, this current iteration of the guidelines represents really a long history in this space. Actually, the first PAD guidelines, which were chaired by Dr. Alan Hirsch with co-chairs Norm Hertzer and Ziv Haskell, were published in 2005. And at that time, it was really a groundbreaking document to have multiple specialties, medical vascular, interventional radiology, interventional cardiology, and vascular medicine and vascular surgery all working together to develop guidelines. And that first document covered not only peripheral artery disease, but also aneurysmal disease, mesenteric and renal disease, really covered all of arterial disease at the diaphragm, below the diaphragm level. There was another update in 2011 to that document, which was very focused only on a few specific recommendation areas. And then the last extensive guideline, which focused only on lower extremity peripheral artery disease, was published in 2016. And that was a multi-societal effort. And now, many years later, we just published, after about 4 years of work, the 2024 PAD guideline update. So this guideline focuses on atherosclerotic lower extremity arterial disease. So we're not covering thrombosis or vasculitis or compression syndromes. We're really focusing on atherosclerosis, and specifically atherosclerosis involving the aortoiliac segment and down. The guideline is very comprehensive. Again, it was a 4-year undertaking, and it really covers everything from initial evaluation of the patient, identifying patients at risk, diagnostic strategies, a very expanded section on medical therapeutics, an expanded section with the addition of a podiatrist to the writing committee in partnership with the American Podiatric Medical Association on foot care, preventive foot care, therapeutic foot care, offloading in the setting of severe ischemia. Big section on exercise, because structured exercise therapy is such an important component of care for patients with PAD. And then about half of the document focuses on some of the more severe symptomatic subsets and revascularization. So we focus on revascularization for patients who have chronic symptomatic PAD that's more stable, like claudication or other exertional leg symptoms. We have a section on revascularization and care for patients with critical limb-threatening ischemia, or now it's called chronic limb-threatening ischemia. And then we have a section on the care of patients with acute limb ischemia, where they present within 2 weeks with an acutely underperfused ischemic limb. That's usually a thrombotic condition. The document rounds out with a section on longitudinal care and the vital importance of longitudinal care and what are the elements of longitudinal care. Then we talk about research priorities and kind of next steps, future directions, and advocacy priorities. Well, I think there was a lot of new evidence since the previous go-round. I don't know if I can hit all of the changes. I'll encourage the viewers and listeners to take a look at the document. But I think, to summarize, going from beginning of document to end, one big change is really wanting clinicians to recognize the clinical subsets of PAD. When you have a patient with PAD, what is their current clinical status? Are they not complaining of leg symptoms, although they may be functionally impaired? Do they have stable leg symptoms, again, claudication or other walking impairment? Do they have the chronic limb-threatening ischemia? That's severe PAD with ischemic rest pain, ulcerations. Or do they have acute limb ischemia, which is really an acute emergency, which is usually a thrombotic occlusion of the artery? So we want people to recognize those clinical subsets. I think the next major new piece is, and very important piece, is a very expanded section on the very important and often devastating consequences of health disparities in PAD. We have patients of color who have much worse outcomes in PAD, less likely to receive effective treatments than white patients, and other disparities related to geographic location, socioeconomic status. So there's a whole section on recognizing those disparities in PAD. We also have an expanded section on recognizing that there are some conditions that synergize with PAD to put the patient at highest risk of cardiovascular or limb event. We call those risk amplifiers, and they include things like diabetes, continued smoking, chronic kidney disease, and even something like depression can actually interact with PAD and be associated with worse outcomes. So a nice section on that. We also have a section on management of PAD in the elderly patient and geriatric syndromes and how they may play a role in determining a care plan, including whether revascularization is appropriate. On the medical therapy side, I'm honestly most excited about that because I'm a medical vascular specialist, so medicines are my intervention. Making its first appearance in the PAD guideline is the use of antithrombotic therapy with low-dose rivaroxaban, 2.5 milligrams twice daily, in combination with low-dose aspirin to prevent cardiovascular and limb events in PAD. This is the first time that effective therapy has appeared in the PAD guidelines. Also making their first appearance in recommendation statements on the lipid side, in addition to high-intensity statin therapy for all patients with PAD, for those who have not yet achieved their LDL lowering targets, and especially those with those risk amplifiers, we now have recommendations regarding PCSK9 inhibitors and ezetimibe. And then again, on the diabetes section, making their first appearance in the guideline for patients with PAD and type 2 diabetes, there are some recommendations regarding the use of GLP-1 agonists and SGLT2 inhibitors. So a lot on the medical therapy side. As mentioned, we have a whole new section, expanded section on foot care. And one of our collaborating organizations was the American Podiatric Medical Association. And we had a wonderful podiatrist, Dr. Evans, on our writing committee. So a lot of information on preventive foot care and engaging podiatrists in the care team for patients with PAD. Then we move toward the revascularization-oriented sections. I think the part that's most new is the section on chronic, I'm still getting used to the new nomenclature, chronic limb-threatening ischemia, CLTI. And we had some new trials to consider. There was the BEST CLI trial and the Basel II trial, very important seminal trials in terms of revascularization strategies for CLTI. And the group discussed that data. And there are a number of recommendations for CLTI. We really strongly recommend multi-specialty care teams to evaluate patients, determine the best strategy for revascularization, preserving as much of the foot as possible, medical therapy, and follow-up. We strongly recommend revascularization for patients with CLTI. It's really vital that all patients be evaluated for revascularization, certainly before amputation, and really have some algorithms where it's a very patient-centric approach. We have these trials that provide us some insight in terms of factors to consider, such as assessing for venous conduit for potential surgical revascularization, assessing patient risk, and then really have an algorithm there that helps in terms of deciding what is the best revascularization approach for the patient with CLTI. I think those are the highlights in terms of what's new. There's a lot of other material in the guideline to read. Well, I think the highlights are the ones I mentioned. I mean, we have a new class 1 recommendation for the use of rivaroxaban, 2.5 milligrams twice daily. That's low-dose rivaroxaban and low-dose aspirin in patients with PAD to prevent cardiovascular and limb-related events. And then we have some recommendations where other medical therapies may be considered atop the high-intensity statins. That would be the ezetimibe and the PCSK9 inhibitors can be added to achieve the LDL targets. And then certainly for the patients with type 2 diabetes and PAD, we have new recommendations regarding considering the addition of SGLT2 inhibitors and GLP-1 agonists. I think we're all very excited about the recommendation that patients with CLTI in particular should be cared for by a multi-specialty team. And certainly if amputation is being considered for that patient, a team should be engaged to just make sure, is that patient truly a no option patient for revascularization, or might another provider have another strategy to offer? And I think we all felt like when patients are discussed among different specialties, sometimes there's new insights that can be gleaned and a care plan put together to preserve as much of the leg and foot as possible. Yeah, I've spent the past 4 years of my life working on these guidelines, and I'm very excited about them, but they're useless if they stay in an electronic web space or in a paper file and are not implemented. So I'm really hopeful that these guidelines will be implemented broadly. I think, unfortunately, study after study has continued to show that patients with peripheral artery disease are less likely to receive treatments recommended in guidelines, simple things like antiplatelet therapy and statin, than their counterparts with coronary artery disease. And some of our recommendation statements, honestly, are not that different from, I mentioned 2005, yet there's still not robust and broad recognition of PAD, implementation of medical therapies, and then getting patients exercise or revascularization when needed. So I'm really hoping these groups will implement these guidelines. I know many of our collaborating organizations on this document, there were many organizations involved, are already working on initiatives to educate providers about the guidelines and also tools for implementation. I will say the American Heart Association has launched a very ambitious national in the United States peripheral artery disease action plan, and activities related to dissemination of the guidelines are included in that action plan. So I'm hopeful that these guidelines, now that they're completed, will be implemented. I'll tell the clinicians listening, we have some very nice figures and algorithms that were really designed to be very user-friendly and easy to implement in clinical practice. So I suggest, if you don't have time to read through the whole document, at least take a look at those figures. The one thing I will say is, one thing I'm most proud of in terms of this document is the multi-specialty collaboration, and the fact that we had vascular surgeons, interventional cardiologists, vascular medicine, interventional radiologists, podiatrists, patients, nurses, and many other specialties working on this document and coming to a consensus after reviewing the data is something I think is very important about this document.